So good morning to everybody. Before we start with our presentations, that every doctor will provide his personal experience and our feedback from all the trials that we do on clinics, I would like to ask you to be more interactive today because we are few people. So how many of you do you have a CBCT up to now? Okay. And the rest of the people, you have a CT or you don't have and you want to get a one in your practice? CT and MRI, okay. Which type of CT?
It's, I don't know how to explain it in English, I'm sorry.
How many slices?
It's 3 slices.
Huh?
It's
Two slices, okay, that's good. Perfect. What I am asking is that today we will present you the up-to-date what we do with this machine, and in the afternoon I will present you what will be the future in the next few years, what we are going to do in our daily practice, and I will try to give my personal approach as a radiologist, how it would be an important tool in your daily practice. So all we know that a CBCT is a cone-shaped X-ray beam that produces the 3D images of anatomical structures. And unlike the traditional CT, take the helical pattern with many slices. So the CBCT was well known in the human dentistry. And it's clear to most of us that up to now, we use the cone beam CT for the scalp, for the dentistry and the oral surgery. We evaluate the tooth root health, the periodontal disease, and mostly it's very important like in small breed dogs or feline patients. We could evaluate complex fractures and with the impacted on unerupted teeth. And what we provide with the CBCT, we have a more detail than traditional dental radiographs and less distortion. We can see the nasal passages, the sinuses, and the acoustic canals, and we use it a lot in the pre-surgical planning, and we evaluate also the tumors and the fractures. And it's very beneficial in the brachycephalic breed with complex skull anatomy. In the orthopedics, also Professor Martini will go deeper, we use it as a pre-surgical planning, and we use it a lot for the diagnosis for elbow, mostly for elbow and less for hip dysplasia, bone tumors, and non-union fractures. And we will explain to you in the literature why is that. And also it's very great for small structures. If you consider small breed dogs, carpi, tarsi, I prefer it a lot. And obviously with the exotic animals, as you know in your daily routine, you would have like pets from 50 grams to 65 kilos. So this is not, it's not easy to say that with the one machine we can do it everything good. So what are the advantages that we have with this technology? We have a high spatial resolution. It's good for small details, lower radiation dose. We are reached like fast scan times, and it's a compact size of the machines, and it's cost effective. As you consider, I'm an owner of a diagnostic imaging center, and I have both a CBCT and a CT. For a big CT unit, I'm paying 5,000 euros per month only for the maintenance. So a CT it costs a lot. What are the limitations? We have a lower contrast resolution compared to standard CT, and I will explain in the next slides in which technology of cone beam CT we have lower contrast resolution. Now, we use it mostly for bone and air-filled structures, and we have motion artifacts that we have with a breathing animals or the cardiac movement. And this is something where we are working with the anesthetist, and we'll have also a presentation later. I had a presentation like 3 months ago in Greece, and my personal approach as a radiologist is based on the Vimago. And I'm not, when I present, I say my opinion, I'm talking about a specific brand, a specific model, because I've seen a lot of friends, we have some Greek friends, like in Germany, they bought a CBCT, and they don't have the soft tissue algorithm. That's why I always say that I'm doing the comparison. In my daily practice, it's like more than 1 year that we're collecting all the data. I have the CT, I have a 128 slice CT and a VMAGO, and we're collecting the data, and we try to publish. In the next months, we will publish what we're going to see, what we see with this machine, and if it's better or not, or if it's similar, the results. So it's very important for us to understand what we can do and where our advantages or disadvantages, and what is your caseload, where is your target, what you want to see. With this machine, you can have like a digital radiography, you can do fluoroscopy, and you can use it as a CT scanner. So, like, it's a very nice tool to have it. I would like to thank also Imaginalis that called me, like, it was an invitation to experience their technology like 2 years ago. Until then, I was not a fan of cone beam CT. I was a radiologist in a big brand, and we're having a lot of cases from all over the world, from Japan, States mostly, UK, Europe. And when you have a CBCT, the same company said, we don't accept clients from CBCT because we don't have a standard quality of images. So we cannot report. Sometimes we had a CBCT of the head, and I couldn't distinguish like the muscles from the lymph nodes. So it was dangerous for us to send a report. And that's why is the main cause of the rumor that CBCT is not good enough. So after 2 years that I'm evaluating machine, I was like applicator specialist also in GE, so I go in the deep knowledge of the machines. At the beginning, I was like not a fan of CBCT, and now I'm becoming more fan of CBCT rather than advanced CT. And our studies that we are now doing is when you compare something, you have to compare similar things. So when you go, a me vet is going to buy a CT, so it's going to be an entry-level CT of 16 slices that they call it 32 with all the software applications. What does it mean? That you have a small detector, a slow machine, small tube, and so you have a lot of limitations in your daily practice. That's why I'm trying to compare now, we're collecting data, comparing the VMAGO with an entry-level CT, and also with a high-level CT, the 128 slices. So in my experience, I will give you also clinical cases, in which cases I say to my residents, don't do the CT, go directly to the CBCT. So there is the VMAGO with a fixed bed, or the PICO with a mobile, mostly for who does surgery. And what we like, as I told to all my colleagues in Italy, that yeah, I'm sure that the CBCT is better for the carpi, but we have to prove it. I'm sure that we can see the pulmonary metastasis. We have to prove it. That's why I will go back in the literature, what we have up to now, what was the years that we have a lot of evolution in the literature, and what we will provide in the next years. So we can see that in 2017, they started to demonstrating research about the landmarks in the medium-sized brachycephalic dog. Why is that? Because who does dental radiographs in a brachycephalic, it's like insane. Trying to take radiographs in a brachycephalic, you need half a day of your routine. And then you have superimposition, distortion, and you cannot decide well. So CBCT was better suited than dental radiography for the identification of the anatomic landmark in brachycephalic dogs. Why? We have bone cysts, eruption cysts, and all this pathology that dentists are more familiar, and they want the precise landmarks. 2019, still we're going for the cats. Why is that? Who has a CT? I have a CT. You know, for the cats, you have to stress a lot your machine, and sometimes you're missing some dental issues. While with the CBCT, it's demonstrated that we have well presentation of all the dental alveolar lesion in cats, and you can see the anatomical structures. 2020, there was the biphasic calcium phosphate in mandibular defects in dogs, so the use of CBC to evaluate the bone healing. And also, it was the know its secrets, how the cone beam CTs work. So the fundamental difference between CBCT and spiral CT is that CBCT utilizes a cone beam shape, so the area of the detector captures a full volume of image in a single rotation. And also is an effective assessment of bone healing. So these are two very important things that we have to reach in every daily routine. Then in 2020 again, we have the novel of method for canine eruption assessment. So you know that the owners are stressing a lot, they demand the best quality. So I was working with Grazis in Novara, and I see that the dentists now, they're very important for the vets. So CBCT was their favorite tool. As we know, and we were speaking about in the next slides about the brain biopsy, we know that we have the brachycephalic, mesocephalic, or dolichocephalic patients. So our skull, we have to evaluate different type of skull. It's not like in humans. So we did, in 2021, there was a comparative morphometry of TMJ joint in brachycephalic and mesocephalic gut using multi-slice and CT. And they say that we have similar and accurate images for bone. In my personal opinion, in feline patient or small breed dogs, we have more data in CBCT rather than CT. Then we have the septic arthritis of the TMJ. So conventional CT and CBCT display better diagnostic performance in identifying osseous structures and diagnosing bone changes, in identifying spatial location or interface with metal implants, if present. What we can do, like for example with a CBCT that I was discussing previously, if you have a CBCT that has only the bone algorithm, you cannot see the subchondral tissue or the soft tissue, while with Imaginalis we can see also soft tissue, so you can have a better assessment of the joint, rather than going to an MRI that you can see the synovium, you can see the amount of fluid that you have, but it's something that costs a lot and takes a lot of time. The 3D printing is something that is the new fashion that we have, the virtual 3D printing, or the handmade seed 3D printing that it was using for the arthroplasty in cats. So they concluded that TMJ gap arthroplasty in cats, it was a procedure that indicated in case of severe intra-articular, extra-articular ankylosis. And who has cases of dental issues. Sometimes we have in puppies in utero trauma, and we have a bridge of bone tissue that is providing ankylosis. So if you see cases that you have in the lateral surface of the mandible, you have a bone bridge that is going from the mandible to the to the TMJ, and you have ankylosis. Usually this is what's happening in utero trauma, and then the new bone formation is producing. And surgically, you have to know the margins in order to cut it wide, because this new bone formation is remaking and renovates on the ankylosis. And I'm sorry, okay. So the CT changes of the temporomandibular joints. Again, 2023, we have the first molar roots, the mandibular canal, using the cone beam CT in order to know the location or where we have some abscesses, and the prevalence of root fusion in canine, maxillary, second, and molar teeth using the cone beam CT. So up to now, as you can see, we have a lot that are describing the skull and the teeth. In human medicine, there is a feasibility of bone marrow edema detected using dual energy cone beam CT. This is something that we like it a lot for the orthopedics, because also in MRI, the bone marrow edema also for mostly for the femur and the femoral condyles. We don't have the clinical impact of that, but in human we know that the bone marrow edema provides pain. While in human, it was 2008, they were describing how it's working and what they're doing. So we can see that we are like 20 years behind, and we are still talking about the teeth. It's easy to understand who does equine, that CBCT has a very nice impact in the equine medicine. And we have also a lot of investigation about the cone beam CT that agreement it detected dental and sinus abnormalities in equine cadavers. And also in the caudal cervical articular process. I was in La Cyrale, I don't know if you want it, it's the best training center for sports imaging equine, and they had a CT, and it was stressed to do the caudal cervical. While with these machines you can go in the caudal cervical, and now we evaluate also in the equine that we have the similar wobbler syndrome in equine. That's why the caudal cervical is very important to go. What we want in daily practice, we are vets. We invest money, we invest time. Our clients are living beings, so we have to respect them. So every money is not only, we have the manager, most of you have the manager in the clinic, you have the accountants that they have to work for that. But our purpose, our scientific approach is that we have to be smart, giving the best solution with a better way. So the manager should be happy that our business is going well, and our quality of images, how we have to be fast and efficient. That's why I will provide you some cases, what we reached, comparison like to the CT, what we can do, because when I was in the company and say, yeah, we could have a client with a CBCT, but I would say, yeah, but can I see a brain tumor? Can I see pulmonary metastasis? Can I do a total body? What we can do? Let's see some cases. So this is a dog with a choroid plexus tumor. So as you can see, in this case, I don't stress a lot the contrast. We can see that we can depict the contrast medium, we can depict the vessels, we can depict the mass effect. So does a CT provide me further information? No. So this is a target that we reached. This is a very nice case. My resident lost the lesion. This is a small, early meningioma in a feline patient. It was a routine. It was, the cat was not feeling well, so the colleague from Cyprus did a CT, and I told him, nice, you saw that you have an early meningioma. It's so tiny. If you go fast in a CT with a feline patient, in my opinion, you could miss it. And also in the CBCT, you have to be very focused. But this is something that is a very nice, and I'm happy that we can demonstrate that we have cases like this. Dr. Kuka will go deep in the CT myelography, but with the colleagues that they have the CBCT, I tell them, if you do the spine, yeah, sometimes we have artifacts in the IVD space. Yeah. If you combine with a myelo-CT, you rule out all the surgical cases. What you cannot rule out is like the infarcts, but it's not surgical. So, in my opinion, in daily practice for the vertebral column, if you want to see if it's surgical or not, CBCT is more than enough. And with a fluoroscopy, Dr. Kuka will explain, I think he's more experienced in that. With a fluoroscopy, you could do also the myelo more effective, more fast, and to be more secure if you're not well experienced. But where I'm focused, as you see in the literature, was only on teeth. What we do care now, mostly, it's the orthopedics, yeah, a lot of cases with the CBCT, but it's easy to understand that the carpal tarsi are very well presented with a CBCT rather than with a CT. What we will ask a lot is a total a whole body CT for neoplasia. This is a nice case from Genova Vet, from colleagues, that they're using that to do the whole patient, and they have mammary glands, and you can see the metastases in the abdomen, you can see the metastases in the lungs, so you have the full staging of the patient. This is something that I know, I will show to you, and in the next few years we will demonstrate it in the literature. So it has to be evidence-based. Could we see a shunt? 2 years ago I was saying to Leonardo, no, you cannot do it. And yeah, they work a lot, and they demonstrated that with a soft tissue algorithm that they provide, we can see the shunt, we can do measurements. So I'm feeling confident that to do an angiographic study of the abdomen and provide to the surgeon all the details, while I was aware 2 years ago. And I'm not showing only the good images, I'm showing also the bad images. This is a study that it was late at night in Cyprus. There was a vet that was not familiar with the machine. The patient was not stable. And he sent me this CT scan without contrast medium. And I could depict that it was a ileochicocolic intussusception. And I sent it immediately to surgery. So, could be a tool for emergency cases, yeah. This is a video of Imaginalis that they do CT arthrography. I think it's from Professor Martini. So this is a normal case. I'm doing MRI for the stifle. And I had a low field MRI years ago. It was very difficult to do, to have a standard protocol equality for the stifle, because we have small breed dogs, large breed dogs, so you have two different coils. And I was not sure. When a vet was calling me and I said, could you do me an MRI of the stifle? Yeah, I say, let's see, but we could miss something with a low field. Now I have a high field. And with a high field, what I'm doing, I'm investing in a lot of coils, if you know from MRI. So you have to invest a lot of money to have different coils for a large breed dog, a medium breed dog, and a small breed dog. And you still have limitations. And you need time. What we do now, with most of I have a very friend of mine in Cyprus, that we do all the stifle with a CT arthrography. And after like less than a year, I'm feel confident to say if you have like a meniscal tear or not, or a rupture. That I was aware of that. So this is something that all the radiologists will have to be comfortable, provide the literature, and then say to the vets, yeah, you can do it, because we can report it, and then you can be sure. For the exotics, I skip the 128 slice CT that I have if I want to see exotics. I have cases that I was saying, I remember that I have 3 premolars and 3 molars. Where's the third one in the CT? And then I did the CBCT and says, oh, now where is this? Because I have better resolution. I was missing a tooth in the CT, and I couldn't depict it. And I stress also my applicators to work in the filter back projection, in iterative reconstruction, nothing. I couldn't do it. So when I do exotics, I go directly to the CBCT. This is a chameleon that you have a lot of nodules, cutaneous, subcutaneous nodules. They had a neoplasia, and it was a nice pet. Everybody took photos for the Instagram, in clinics, you know. And in 2015, we have to prove that we see the contrast medium in rabbits. So now we know, the team for Imaginalis knows well that they can reach the goal. We have to publish it. But based on my experience the last year, I feel so comfortable that we can see the contrast medium, we can see the vessels, we can see the lesion. Yeah, we cannot measure the Hausmann units, but we can provide other skills that I will show you that are better than measuring the Hausmann units, because also if I measure the Hausmann units, I have to do an FNA or biopsy. Dynamic CT is not useful, for example, for the hepatic lesions. So whatever the enhancement, whatever the wash in and wash out it is, you have to take samples. So why don't you have a tool that guides you to take the samples? This is what the fluoroscopy will help you. You can do a swallowing study. Easy to understand that we need a fluoroscopy to do swallowing study, and it's very common that they demand a swallowing study in clinical cases. But what I prefer is the guided FNA. So you do the study, you see the hepatic lesion, you go guided, you are secure, and you can have a standard protocols with your team. Because consider that you are the main person in the clinic, and you do the CT, you're easy going to do FNA, but all your other colleagues are not that confident. If you provide them a tool that secures them the direction, the depth, they feel more comfortable. So your quality is more standard. So in conclusion, what's my up-to-date opinion about CBCT? I'm getting more towards CBCT. So if I have a vet, because I have a lot of questions in Greece, what I should buy, a CBCT or a CT? And I say, depends how many cases and which type of cases are you dealing with. If you do orthopedics, it's easy to understand you need a CBCT because you can see the bones, you can see the small structure like tarsi, carpi very well, the elbow dysplasia. I prefer it because also in CT for the orthopedics sometimes we'll say, okay, if you need bones, you go to Siemens because they have the iterative reconstruction, while the G you have to bring the applicator to enhance the iterative reconstruction in order to see better a non-displaced fracture. So it was easy to understand, like if you do exotics, because they're small, so the dimensions are very small, you need a CBCT. A lot of colleagues, when they send me like a small parrot and they do the CT, I say to my colleagues, have you done the ultrasound or have you done the CBCT? Because with the CT, we are so limited. With the MRI, sometimes you can see, because I have these small coils that I'm using for the rats, that is some rings coil that we use for the TJ in humans. So you have a 3 centimeter field of view. But also there, I have limitations. The most important question that we have, and I think also you in Greece and in Italy, we have the oncological cases. Oncology is 80% of our cases. Because the orthopedic cases, they go to the surgeon, go to the orthopedics, go to specialists, and they have the cases, the neuro cases, they go to them mostly. But you can do the myelo CT and to see that if you have a neoplasia or if you have a IVD disease, and then speak with the specialist. But the oncological cases are dramatically increased. So I'm very happy that we reached, with all the scientific team, that we can do protocols of the whole dog, the whole cat, and then in the next speech I will talk about also lymphography or what else we can do in the future. This is something that when we decide to have a technology, it has to be efficient. And I'm glad now that I'm saying, based on my data up to now, the entry-level CT comparison with a CBCT, I provide to small clinics or also to big clinics, I provide that they should have a CBCT. And in Greece now there is a big fund that they're producing like a diagnostic imaging center. I said, you should have standard a CBCT. And when you buy a CT or a CBCT, the same day you should buy the ventilator for the apnea and the power injector for the contrast medium. This is something also in CT, but also in CBCT, is mandatory to increase your image quality. Thank you all.